Let's begin with the first section of our lecture, testicular cancer. And in this section, we will talk about the primary germ cell tumor of the testes, one of the most common type of testicular cancers developed from primary germ cell. So the incidence and epidemiology of primary germ cell tumor, we will talk about that. Also, what are different causes and the genetics involved in the primary germ cell tumor of the testes, and also how they present and lymph node involvement that occur in the primary germ cell tumor of the testis. So let's begin with our section, and in this, the primary germ cell tumor of the testis. If you see the diagram that gives you the picture of primary germ cell tumor of the testes, that's the testes, and that's the close-up of the germ cell tumor of the testes. So malignant transformation of a primordial germ cell. So once the tumor develops from the germ cell, which is primary germ cell tumor of the testes, as with any cancer, there is malignant transformation that occurs in the primordial germ cells that can lead to the changes that ultimately develop the germ cell tumor of the testes. So malignant transformation. 95% of all the testicular neoplasm are the germ cell tumors. The remaining 5% are other different types. So primary germ cell tumor, they originate. Primary is different from secondary because primary, they originate from the testes, from the germ cell, primordial germ cell of the testes, and the secondary are the one from that metastasize to the testes. So 95% of testicular neoplasm are the primary germ cell tumors. They arise from extragonadal site, like extragonads, from the sites other than the gonads. Gonads are the testes in the male and ovaries in the female. So extragonadal means other than the gonads. Some other sites from which they arise are the mediastinum, retroperitoneum, behind the peritoneum, and very rarely but from the pineal gland. So these are the extragonadal sites for the development of the testicular germ cell tumor, testicular tumor. There are mainly from the testes germ cell, but there are sites which are other than the gonads, other than the testes, and these are the mediastinum, retroperitoneum, and in rarely it's the pineal gland. Totipotent capacity for differentiation of tumor cells. 95% of the cancers are cured, and the totipotent cells have the capacity for differentiation for tumor cells. Totipotent cells are the cells that give rise to different types of cells later on. Different types of cells originate from the totipotent cells, and these tumor cells have totipotent cells have the ability to differentiate into tumor cells, but 95% of these can be cured. Next, the incidence and epidemiology of the primary germ cell tumor. In this diagram, you can see this is the prostate, then the urethra coming out from the prostate, and then the penis. Site of the cancer. That's the site of the cancer in the testes. So this is the scrotum. So the site of the tumor here you can see is the testis, testicular tumor. Incidence and epidemiology most frequently in men between 20 to 40 years of age. So testicular cancer is the cancer of young age, not old age people. Men, it's the young age between 20 to 40 years of the age, which is mostly affected by the testicular cancer. Testicular mass in male is more than 50 years called lymphoma. So if it is after 50 years of age, that mass in the age after 50 or equal to 50 is known as the lymphoma. Germ cell tumor 4 to 5 times more common in white than in African American males. Very important epidemic evidence is the cancer, testicular cancer is more common in white men as compared to African American men. Higher incidence in the Scandinavia and New Zealand. So it's more common in white males. That's why in New Zealand more population is white population. Scandinavia, so incidence is more in those regions. So some very important points as far as incidence and epidemiology of testicular cancer is associated mostly in the age between 20 and 40 years. If it's after the 50 years of age, that mass in the testes is known as the lymphoma, more common in white men as compared to African American men, and it is more common in Scandinavia and the New Zealand. So these are some important points regarding the incidence and epidemiology. Next, etiology and genetics. Etiology is the causes. Very, very important cause, common cause of the testicular cancer is cryptorchidism. Higher risk. Cryptorchidism is undescended testes, testes that do not descend into the scrotum at birth. The scrotum is empty, there is no testes present, and these testes are usually in the abdomen, so it need to be fixed. Procedure known as orchiopexy is performed, in which the testes are brought down into the scrotum, and it's very, very important because one, the higher risk of development of cancer, and the other is infertility is common in men who have cryptorchidism or undescended testes. Abdominal cryptorchid testes, so they are in the abdomen, not in the scrotum. At higher risk, cannot be brought into scrotum, removed. So it's important, if orchidopexy cannot be performed, if the testes cannot be brought down into the scrotum, they must be removed. So one of the or the other has to be done. Orchiopexy is done before puberty, should be done, in which the testes are brought down into the scrotum, and that reduces the risk of germ cell tumor. So very important etiology cause is the cryptorchidism, undescended testes, in which the testes are in the abdomen, not in the scrotum. They have to bring down in the scrotum before the puberty. If they cannot, we should do the removal. 2% men with germ cell tumor in one testis, primary tumor on the other side. So 2% of the cases, if there is germ cell tumor in one side, it is the primary tumor is present on the other side. Other causes and genetics, testicular feminization syndrome. It's a syndrome again in which can lead to increased incidence of testicular cancer. Testicular feminization syndrome. Family history increases the risk. Klinefelter syndrome is also associated with mediastinal germ cell tumor. We talked about the 2-3 extra gonadal sites of germ cell tumor. One of them was mediastinum. So this type of germ cell tumor that arises from the mediastinum, it increases in the syndrome known as Klinefelter's syndrome. Isochromosome of short arm of 12p, and then it's pathognomonic for germ cell tumor. So in the genetics, if there is abnormality in the chromosome P12p, which is the short arm, Q is for the long arm. So if the short arm is there is isochromosome, there is similar mirror image of short arm of chromosome 12p. It can lead to increased incidence. It's very, very significant, pathognomonic of the germ cell tumor of the testes. So very, very important points we discussed in the incidence and epidemiology, and also in etiology. Cryptorchidism, very important factor leading to increased risk, should be treated by orchidopexy or by the removal of the undescended testes. Other factors that can lead to the tumor, germ cell tumor, we have the testicular feminization syndrome. If there is a family history, there is increased chance to develop. Klinefelter syndrome is another isochromosome of short arm of chromosome of 12p, and that's pathognomonic of germ cell tumor. So all these are very, very important factors or statistics related to the germ cell tumor of the testis. Clinical presentations of the germ cell tumor, we have, this is the diagram that gives the tumor in the testes. This is the epididymis. Then we have testicular artery. Painless testicular mass is present. The painless mass should also alert the patient or the physician that it might be a cancer. So painless testicular mass, testicular discomfort or swelling, suggest epididymitis or orchitis. So if there is pain present along with the mass, usually it gives the indication that there might be some infection or inflammation like epididymitis or orchitis. Inflammation of the epididymis here, this is the epididymis, or the inflammation of the testes itself, which is the orchitis. Testicular ultrasound examination should be performed. Radical inguinal orchiectomy. Orchiectomy is the removal of the testes, or orchi is for the testes. Ectomy is the removal, so radical inguinal canal through the inguinal, the orchiectomy should be performed. Radical inguinal orchiectomy. And the inguinal approach, usually why it's preferred, because it avoids breaching anatomic barriers. So the access through the inguinal canal is important. Next, some more clinical presentations which are mostly associated with the metastasis of the germ cell tumor. Back pain. Back pain occurs if there is retroperitoneal metastasis. Retro means behind the peritoneum. If there is metastasis, it can cause back pain. Dyspnea, difficulty in breathing from pulmonary metastasis. If there is a spread of the tumor to the lungs, it can cause dyspnea. Gynecomastia, enlargement of the breast in the males. This is due to the high HCG, human chorionic gonadotropin. Delay in diagnosis, more advanced stage. The more the delay, the more the advancement or the spread of the tumor. As with all the cancers, early diagnosis is very, very important, so we can diagnose the cancer at the earliest possible stage, so the prognosis would be better. Staging evaluation for germ cell tumors. Determining serum levels of alpha fetoprotein, HCG, lactate dehydrogenase. So it's very important that we should evaluate the level of measurement of the levels of the alpha fetoprotein, HCG, lactate dehydrogenase. They are very, very helpful in the staging of the germ cell tumor. A CT scan after orchiectomy of chest, abdomen, pelvis, stage 1 disease limited to testis, epididymis or spermatic cord. Stage 2 disease is limited to retroperitoneal lymph nodes. Stage 3 is outside the retroperitoneum and it involves the supradiaphragmatic nodal sites or viscera. Supradiaphragmatic, above the diaphragm, which is the muscle, major muscle of respiration that separates the chest from the abdomen. So above supradiaphragmatic node sites or viscera organs are involved. So that's very important for the staging of the germ cell tumor. We need to measure the level of some tumor markers like alpha fetoprotein, HCG, lactate dehydrogenase level, and then we divide the CT scan should be done after the removal of the testes, looking for any metastasis to the chest, abdomen, pelvis. And also we stage it into 3 stages, stage 1, 2, 3. 1 is limited to the testes, epididymis or spermatic cord. The stage 2, now it's limited to retroperitoneal lymph nodes, and stage 3, now it extends outside of the retroperitoneum and also the supradiaphragmatic nodes and the viscera. So that's how we stage germ cell tumors of the testis. Some pathologic staging is defined by operative procedures. So pathology, when we look the structure, organ that is removed, what are different pathological changes in that, if there is necrosis or anything like that, is usually done by after the operative procedures that remove the tissue for us to examine. So pathologic staging, clinical staging, defined by the physical examination, blood marker evaluation, and by the radiographs. So pathologic staging by the procedures. Clinical staging by the physical exam is one very important factor that play an important role in the clinical staging. Blood marker evaluation and also the radiographs help to do the clinical staging. Lymph node involvement here, these are the testes, you can see the urethra, and this is the cancer. That's the vas deferens from the epididymis. This is the cancer. Now the lymph node involvement in the germ cell tumor, we have first by right testicular tumor, interorchidic inter-aortocaval lymph nodes below renal vessels. So first, the metastasis to the lymph node occurs from the tumor that is present in the right testis, and this is that also spread to the inter-aortocaval lymph node below the renal vessels. Then from the left testicular tumor, the lymph node first involved are the nodes lateral to aorta and the below the left renal vessel. So that's the difference and how the lymph nodes are involved. The involvement of the lymph node is first by the right testicular tumor, then by the left testicular tumor. One is below the renal vessels, then the left one is below the left renal vessels and lateral to aorta. So that's the difference between the lymph node involvement between the right side tumor of the testis or the left side tumor of the testis. Retroperitoneal nodal spread, inferior contralateral contra on the opposite side, inferior the lower part, extend to. So first, the retroperitoneal lymph nodes which are involved as we discussed in the staging, then retroperitoneal lymph nodes which are involved first in the inferior region or opposite side. As they spread, cephalad means cephal towards the head, upward. As they extend cephalad, they can go to retrocrural, posterior mediastinal nodes and supraclavicular, above the clavicle, mediastinal and retrocrural lymph nodes are involved once the lymph node metastasis spread, and first the inferior and contralateral side is affected. Treatment is determined by the stage, as with any cancer, and the histology. And the histology is important in staging and the cancer, which tells us how differentiated the cells are present, if they are well or poor differentiated. So that was all about the section 1. Thank you for watching sqadia.com.